Everybody. First, I would like to thank ALS Association Wisconsin chapter for inviting me to talk to you about the respiratory function in patients with ALS. My name is Andrea Anton. I'm a pulmonary critical care and sleep physician, and I have been at the Medical College of Wisconsin for the last 15 years. So it truly has been my privilege and honor to be able to provide care to patients with ALS for the last 15 years. I have no conflict of interest. I am working for the VA, and certainly those are my individual opinions, and this does not represent a VA position. And this is a summary of my talk. I'm going to start with a brief overview on respiratory muscles. We're going to talk about non-invasive ventilation, why, when, and which type of PAP machines, the importance of the airway clearance, and how to augment cough. And I will finish by talking about the invasive ventilation through a tracheostomy. So let's start with the respiratory muscles. So when I think about ALS from a pulmonologist perspective, I know that it's a progressive neurodegenerative disorder that affects the upper motor neurons as well as the lower motor neurons. So when there is loss of upper motor neurons, there is patient experience spasticity as stiffness. And when there is loss of lower motor neurons, whether in the brainstem or the spinal cord, there is evidence of excessive electrical irritability, which leads to fasciculation, as well as loss of connection between the neurons and the muscles get atrophied. And the weakness and the atrophy of the muscle does occur in multiple areas of the body. On the left, you can see loss of muscle on the back and neck area, as well as the hands on the bottom left corner. And on the right, on panel B, you could see tank atrophy and furrowing. And on the C panel, you can see atrophy on the chest and the arms. That this is a patient that has flail arm syndrome. And unfortunately, the respiratory muscles are not spared. They are almost always involved. So this is how I think about the breathing muscles. We have breathing muscles. They are involved with inspirations, and those are the diaphragm and the external intercostals. And then when those muscles are getting overwhelmed and we need additional help, we have the muscles in the neck that are called the accessory inspiratory muscles. And you can see here the sternocleidomastoid and the scalenes are our accessory inspiratory muscles. What about expiration? Well, normally, normal expiration when we don't need any help, this is passive process, is really based on the recoil, elastic recoil of the lung. However, when we need extra help to squeeze air out of the lungs, the abdominal muscle gets involved. And here the picture on the right shows where the innervation of different type of muscles come from. So the diaphragm gets innervation from the top part of the spinal cord, the cervical C3 to C5 level, whether the intercostal muscles and the abdominal muscle get innervation from the thoracic spine. So when the breathing muscles get involved by disease in patients with ALS, patients start having symptoms. And you could see that based on the different group of muscle being effective, patients develop different type of symptoms. So the diaphragm and other intercostal muscle are getting involved. Patients are experiencing rapid shallow breathing with low oxygen levels. And I'm going to show you a little bit later that cough is rather a complex process and involves many muscles. And so the cough gets affected whether the inspiratory, expiratory muscles are involved or the upper airway muscles. And in addition to weak cough in patients with upper airway involvement, those patients are also at increased risk for aspiration. And there are many clues that point to weak breathing muscle. The patients are complaining about inability to lay flat in bed. That's because they lost the diaphragm lost the mechanical advantage of gravity. There is evidence of disturbed fragmented sleep. Sleep is unrefreshing. Patients complain of sleepiness during the day. They wake up with morning headaches or grogginess. They just don't feel like, they feel like they have trouble concentrated when they wake up, trouble clearing the phlegm, choking at night, night sweats, bedwetting are also can be some of the complaints patients may have. And in particular, when we think about diaphragmatic weakness, the symptoms tend to increase as the level of weakness progresses. It may start with first, patient may notice that they get short of breath when they exercise or if they have a physical strenuous duties at work, they will feel unable to complete their work. And then the activity of daily living becomes much harder to accomplish. Problem with phlegm and or secretion clearance. And then as the disease becomes more advanced, patients will have problem laying flat in bed at night, and then ultimately they may develop shortness of breath even at rest. And if we were to do an X-ray, those are some clues where we see the muscles are getting weaker. On the left, you see a normal X-ray. The lungs are nice and tall. Black is air. Heart is in the middle. So you could see that the lungs are pretty normal looking. There's nothing wide or, short looking lungs on the X-ray. On the right, you can see that the now lungs are not as tall. The black is not as is more gray. And here in the bottom of the lungs, you could see there is more whitish, which really signifies that there is evidence of collapse, or the bottom part of the lungs are not expanded and they are not filled with air. In patients that have bulbar onset, they have upper airway weakness, and those patients have problem with swallowing, choking, speech, and hoarseness. So how do we measure the strength of the breathing muscle? So what are the clues that, besides what patients are telling us, that the breathing muscles are getting weaker? So we talk about the pulmonary function test, and many of you know what spirometry is and what the forced vital capacity is. That's a number that many patients can remember, because that's a number that we as physicians are monitoring quite closely. So the forced vital capacity is most commonly used test. There are other ways to monitor the strength of the muscle. Those are the maximum inspiratory pressure and expiratory pressure. We also can measure the Sniff nasal inspiratory pressure. Other ways that certainly I bolded it because with the pandemic and the inability for some patients to travel and get their pulmonary function test, we've been using overnight oximetry quite a bit. So this is a test that you'll have a finger probe connected to a device that wrapped around the wrist, and we can monitor the oxygen level at night. And then certainly there is a blood test that it can be quite painful. We take it out from the artery in the wrist and we measure the oxygen level and the carbon dioxide level. But in general, that is not the test that we monitor routinely, because we know that if we wait to intervene until patients have low oxygen level and high carbon dioxide levels, those are late findings and they are signs of respiratory failure. This is just to show you the forced vital capacity or the slow vital capacity can be done both upright and supine. And certainly for patients that have symptoms and they have normal upright values, we do a supine, so laying flat in bed, and those numbers can drop significantly when patients are in supine position. And we know those are predictors of weakness of the diaphragm. And we also know that a value less than 50% is a predictor of failing breathing muscles. The Sniff nasal inspiratory pressure, just to show you how it's done, it can be easier to be performed in patients that have bulbar dysfunction. It's mainly because they cannot seal their lips around the mouthpiece. And then again, a value less than 40 correlates with low oxygen level at night. So here we talk about the signs and the symptoms that patient experience and the way we are monitoring the strength of the breathing muscle. So let's talk about the non-invasive ventilation. Why is it working? When should we consider it? And which type of machine help our patients? So one maybe short question but complicated answer is that what not oxygen? Why does oxygen is not the option, and why do we want those patients with ALS to use a PAP machine or non-invasive ventilation? It is because the non-invasive ventilation delivers air with pressure and help the breathing muscle and rest the breathing muscle, and in that process, now being able to expand the lung, the patients are able to pick up the oxygen and get rid of the carbon dioxide. So it has been shown that in patients who can tolerate the machines, the PAP machines, the survival improves, the quality of life is better, the breathlessness is better, and we also have evidence that it slows down the rate of the forced vital capacity decline. And we also know that oxygen by itself can depress the breathing and can result in building up CO2, which can result in sleepiness. So in some ways, we call it that it acts like a narcotic. And we also know that from the study that I listed at the bottom is that for patients, they are short of breath, but they have normal oxygen level. Just putting them on oxygen does not improve their dyspnea, does not improve their breathlessness. So we need the PAP therapy. When to start? And I listed the Medicare guidelines. Certainly for me as a pulmonologist working at the VA, I have the advantage to be able to provide a PAP therapy when patients have symptoms at values they are higher than they are listed here. And I can tell you that in Europe, we know that waiting to when the numbers are in this range, it's probably kind of late. But I also can share with you that we are working, the pulmonologist group is working with CMS to update those guidelines. So I would not be surprised that these were about to change in the upcoming future. So what are the Medicare guidelines? It's a combination of symptoms and numbers. And symptoms, I listed just few. So inability to lay flat in bed, waking up at night, shortness of breath, headaches in the morning, excessive daytime sleepiness. And that in a combination with different numbers allows us to prescribe patients non-invasive ventilation. So what are those numbers? The forced vital capacity less than 50%, a MIP less than 60, the Sniff nasal pressure less than 40. And again, that can be upright or supine values. A blood gas that shows that the PCO2 level is over 45, or there is evidence of low oxygen level less than 88% for more than 5 minutes when measured at night. And I alluded to the fact that maybe 50% vital capacity when to consider the initiation of non-invasive ventilation, maybe it's too late. And it's not that it's too late, but it can be much better. And this is one of the studies from Europe that showed that in patients that start the non-invasive ventilation when their forced vital capacity is above 80%, it has a survival advantage. So you can see the difference. And it actually works on all patients, not just patients that have limb onset or non-bulbar. It also works in patients with bulbar onset. So again, it's important, and I offer to all my patients to whether they have bulbar onset or non-bulbar onset, I think they can all benefit from non-invasive ventilation if they can tolerate it. There are different type of respiratory assist devices. Those are what we call the machines that deliver the non-invasive ventilation. And I put it in right just to emphasize that if you qualify based on the different criteria that I shared you before, you do not need a sleep study. Patients do not need a sleep study to start non-invasive ventilation. What I'm not saying is that a sleep study is never needed. In certain patients, your pulmonologist, when they are worried about residual obstruction in the back of the throat or need to titrate the pressures and they are unable to do it at home, may prescribe a sleep study. But again, this is more on an individual's cases rather than a rule. In the past, we used to rely on the different machines. They had fixed pressure, a fixed pressure in inspiration and a fixed pressure on exhalation, and I listed how they were called based on the different manufacturer. And the auto titrating non-invasive ventilator devices, the AVAPs or IVAPs, is the newer technology that's allowing us to deliver variable level of pressure support while reassuring that each breath has a certain depth. And if patients end up needing those machines for longer than 10 to 12 hours, and I would say they use it at night for the entire duration of the night, but now they need it during the day, we switch to more sophisticated machines that are called ventilators, and those are the Trilogy or Astral, and again, based the different terminology or the different name based on the different manufacturers. They do have advantages. They have a secondary mode where you can provide the unique feature of mouthpiece ventilation, and that's able to support patients during the day without having the mask on. And you can see a picture on the right on how it looks like. It offers portability because it has batteries, so the patients are more mobile. And certainly, if a patient chooses to undergo tracheostomy and invasive ventilation, the same machine can be used to provide invasive ventilation through tracheostomy. And one question that you may have is, what is the best mask? And my answer would be, there are different types of masks out there. So it seems like there are many choices. The challenge would be to find the right mask that works for you, and can be a full face mask, it can be a nasal mask, it can be a nasal pillow. Is really working with the therapist, finding what works for you. And certainly we know that in some patients that have a full face mask, that the full face mask can push the tongue backwards, increasing obstruction in the back of the throat. So for those kind of instances, actually a nasal mask may work better. Getting started on NIV is not easy. You need a trained, experienced respiratory therapist that's going to work with the pulmonologist. I am blessed to have a wonderful team that works with me, and really we will work with you to make it happen, and get used to the machine. We can start low and slow, and we can increase on how patient tolerates initial pressure and volumes. We can certainly work with you to find the right mask that would fit without adding too much pressure on the face and the head. I also tell my patients two things. I always tell them they're not born with the mask on their face connected to a machine. So it is work in progress. And it feels like when we remember how we learn how to ride a bike, you're not going to get it right the first time you do it, and more you do it, better you get at it. Better you get at it. How can we improve compliance? Well, it depends what the problem is. We can talk and provide desensitization. We can try different alternatives. Chin strap with nasal pillows may work if the full face mask is too cumbersome. If patients complain of airway dryness, we can add heated humidity and heated wire circuit. If the weight of the tubing pulls the mask off and creates leak, we can help with that. If there is discomfort on the bridge of the nose from the mask or from the strap, we can add padding. If there is rash, we can talk about different creams. And if there is an evidence of nasal congestion, we can talk about different interventions such as saline spray, nasal steroids, nasal strip, so on and so forth. And monitoring is crucial. We want to see how well the machine works for you, how the settings are working, and certainly some adjustments can be done remotely and some need to be done in person. We monitor symptoms. The machines are quite smart. We get a lot of information from a machine. We not only look at how long the patients are using, but we also look at the pressures, at the breath, how big the breath are, how easy it is for the patient to trigger breath, how well mask is fitting. So it's a lot of information. We also may want to do monitor of oxygen levels at night while on the machine. And in very few cases, we need to do blood gases. So again, the blood draws from the wrist to monitor the oxygen and carbon dioxide level. So moving on to airway clearance, and that refers mainly to our cough process. And cough is a complex process, requires a forceful inspiration where the patients take a deep breath in, so the lungs are filling with air. Then the vocal cords shut tightly, so the air becomes trapped in the lung. And then we squeeze the breathing muscles, and then that pressurizes the air and the glottis open and then air comes out. So you could see there is a big cooperation and collaboration between all groups of the breathing muscles. How to augment cough? Well, there are things that can be done by the patient with some help from the caretakers or the family members, and they are effective. And by that, I mainly talk about the manual cough assist, and you can see on the right that it can be done in bed or can be done up in the chair, but does require, and it's effective, it works, but it does require assistance from the caretaker or the family member. If the phlegm is in the back of the throat and it just needs to be suctioned, a suction machine is effective. And I put the link for the breath stacking at the bottom, so you can certainly watch it. And certainly breath stacking is effective. It can help with cough and phonation. When we talk about machine, the mechanical insufflation-exsufflation device or the cough assist, it's again a machine and the mask, and you need some training, and you need settings that again will work for you. So we push the air in, we hold it, and we suck the air out. So trying to mimic the best we can with the machine how cough works. It's very effective in improving the mucus clearance. It helps preventing intubation, admissions to the hospital, delayed tracheostomy, but it can be a challenge in patients that have bulbar dysfunction. And this is an important part that I want to emphasize is that when you combine the PAP machine with the cough assist, they are better together. So this is a study of almost 500 patients from Atlanta at Emory that look at patients who started the non-invasive ventilation early on. So again, you could see their number was quite high, was greater than 80%. And for patients who used it quite a bit, so more than 8 hours a day, and you use it in combination with a cough assist. So they started early, they used it quite a bit, both the non-invasive and the cough assist, and look at their survival. And when you compare that with either no intervention or patients who started late and they didn't use the cough assist and they only use it, more than 4 hours, but certainly less than 8 hours, the survival was about half. So more use, daily use, and start early, and using them together are more effective. And here is, a picture of the vest, and that can help with secretion mobilization. We have some evidence that can reduce pneumonia and hospitalization and may help with dyspnea. Patients with ALS have also a problem with drooling and handling the oral secretions. And certainly we have, a longer menu about the different interventions that we can help our patients who are having problems with that. The top part of my list are different medications, scopolamine, glycopyrrolate, amitriptyline, atropine drops, and certainly some may work better than others. All of them, they have side effects. So it's also a matter of trying to see what works, what are the side effects, and trying the medication that works best for you. For patients who do not respond to this, the next level, and certainly a step up, are the Botox injections. Those can work, but they can worsen the bulbar function, and they only work for about 3 to 3.5 months. So certainly it can work and help with that, but the result wanes over time, and then a new injection is needed. And if not, radiation to the salivary glands can work and can be considered. And surgery is listed. It's listed in the articles. I have not yet seen a patient that requires surgery, and certainly surgery in patients who have limited lung reserve is something that we need to be well aware that it poses additional risks. Now, the last few slides, I'm going to talk about the invasive ventilation through tracheostomy. And here is a picture of the actor James Woods, who did have a tracheostomy, and it was on a mechanical ventilation when he filmed his role in the ER. So delivery of invasive ventilation through tracheostomy needs the placement of the tracheostomy. So that is a surgical procedure. And I would say that that conversation is a personal conversation, and we will help you give you a full picture and help you best to decide with you and your family whether invasive ventilation is tracheostomy is what the patients choose. I tell the patients that it does not change the course of disease, and it does not change the outcome. In average, patients live another 1 to 2 years on invasive ventilation, but the ultimate outcome of the disease does not change. We want to have conversations early on because we would want to do this not on an emergent basis. We would want to plan so everybody can be prepared for it. This is what we try to plan. That's not what we always are able to accomplish, but at least having the conversations early on open this kind of conversation at home as well. In general, what I used to, I consider to discuss for patients who consider tracheostomy and invasive ventilation, they have to have symptoms of respiratory failure, which are low oxygen level, high carbon dioxide level, and they are associated with inability to tolerate non-invasive ventilation. So for them, non-invasive ventilation is not an option, and the forced vital capacity is less than 50%. So they have the symptoms, they have the signs, they have evidence of weak breathing muscles, and they cannot tolerate the non-invasive ventilation. But there is the other group of patients who is able to tolerate, but now the non-invasive ventilation, despite prolonged use, is not enough. They have low oxygen level and high carbon dioxide level. So this is the second group of patients that if they choose to do, that's where those conversations occur. Those is a picture on the right of the home ventilators. And I made this point already that the median survival once patients undergo tracheostomy and invasive ventilation, it's up to 2 years. And for patients who undergo invasive ventilation, the terminal event tend to be respiratory infections, so pneumonias. The quality of life and the ability to communicate may decrease over time, and it's very important to share with us and have your advanced directives in place, because we want to preserve patient autonomy and do what our patients want us to do. And that is the discussion not only with the patient, but with the caregivers. And I can share with you that caregivers do report it's a significant workload, responsibility, requires a lot of support for them, and the quality of the life or quality of life of the caregiver is also poor. What else should we consider? Immunization are extremely important. Influenza, pneumococcal vaccine, nutrition, good nutritional support, avoid losing weight, monitoring for aspiration, treat respiratory infection early, and again, discussing end of life. So the respiratory is something that I discuss with our patients. Again, it's the conversation that we have between all the team members who provide care to patients with ALS. We know that a multidisciplinary approach improves outcomes. I share with you that early non-invasive ventilation works and improves survival. Invasive ventilation, if that is an option that is considered by our patients, and I would say in United States, we have less than 1 in 10 patients that do end up undergoing tracheostomy and invasive ventilation. It's a thorough conversation that covers the tracheostomy placement, the ventilator, the patient, and their caregivers. And it's also important to talk about palliative needs. So the patients have access to medications that control anxiety and pain. And then I could not finish without talking about the COVID-19 pandemic. Unfortunately, in the state of Wisconsin, and I put in parentheses when this talk was recorded, and hopefully by the time I think the talk would be posted until February. So hopefully by February, our numbers would look much better than now. Our community prevalence is high. And the best way to um, be proactive when we don't have a vaccine and we don't have very effective treatment is to have our precaution in place, face masks, face covering. And it's something not just for the patients, but for everybody who comes in contact with our patients with ALS, social, or I would call it the physical distancing and hand hygiene. The influenza season is here, so flu shot is needed. And I think another important part is we are here to see and help our patients. But I can't emphasize enough the importance of the virtual or the video visits. At the VA, we have our own video platform. It's called VVC, but Doximity works just as well. I can tell you those are much better than phone visits. I can look at the patient and look at their neck muscle, how they breathe. One patient wife can help me actually see whether a patient was having swelling in the legs. So we actually get a lot more information if we can see you, So again, I can't emphasize the importance of adding the video ability when if we were to perform a video visit, it's much better and much more meaningful compared to a phone visit. And I am extremely proud to be part of the Zablocki VA multidisciplinary ALS clinic. We are also proud to be a center of excellence in the state of Wisconsin, and our team is big, and we have dedicated neurologists, nurses, physical therapists, dietitians, social worker, respiratory therapists, PAP coordinators, and I am the pulmonologist. We see our patients every 3 months, whether are in person or virtual visit, and I can say enough about how dedicated everybody is, and we really feel to be our privilege and honor to take care of patients with ALS. So in summary, pulmonary involvement is common in patients with ALS. Early recognition of respiratory symptoms and early intervention improve outcomes, and is the power of a team. And the outcomes of patients with ALS who are cared by multidisciplinary teams, it's better. I thank you for your attention. Stay safe and be well.